welcome you and to say thank you for joining us today. I am Trish Hutcherson, Orion Health Corp's Marketing Director, and I will be with you today throughout the session as your moderator. On behalf of everybody at Orion, we hope you enjoy today's presentation. And before we get started, I'd like to quickly run through a few housekeeping items. Today's phone lines will be muted for the duration of the session. If at any time you do have a question, please feel free to enter them into the GoToMeeting dashboard on your screen. Technical and logistical questions will be answered in real time. However, questions related to the content will be answered at the conclusion of the presentation. After today's session, you will receive a short survey, and we'd ask that you complete it to let us know how we did. And with that, I'd like to introduce today's speakers, Elizabeth Hansard and Dr. Howard Robin. Elizabeth Hansard is a certified professional coder and director of coding and operations in our Atlanta office. She joined Orion in 2009. She brings with her a wealth of billing experience to us and has been active in medical billing, coding, and management for more than 15 years. Liz holds a degree in business administration and is currently in the process of obtaining her CPCH designation. Experienced in client management, contract negotiations, medical coding, and customer service, she is equipped to provide excellent services across multiple specialties. Dr. Howard Robin has 37 years of experience directing and operating clinical laboratories in California. He is a board-certified anatomic and clinical pathologist who provides consultations to CLIA laboratories engaged in molecular diagnostic testing. Dr. Robin has extensive experience as a College of American Pathologists laboratory inspector evaluating hospital and commercial clinical laboratories. And with that, Liz, whenever you're ready, please feel free to go ahead and get started.
Thank you, Trish. I'd like to thank everyone for taking time out of their busy day to join our webinar. I hope that each of you can take away some valuable information that can help you with your practice. I'd like to start with an overview of the top 5 coding errors. There are so many different errors that I could talk to you about, but I wanted to give you the ones that just keep popping up time and time again, not only from the coders that I work with, but from the groups that I get to serve and get to audit. The first one is coding with no dictation. Performing a procedure without referencing that procedure within the report and billing that CPT code. There are different items we could talk about, special stains, but I chose to talk about decals because we commonly see it. In our bone marrow cases, the pathologist did a decalcification. I know he did. You know he did. He performed it. He provided the CPT code. It's billed. However, it's never referenced within the body of the report. I mean, for bones, we can come up with definitely multiple cases where pathologists always tell me, when you see a bone, a decal was performed. It can be with your bone biopsies, amputations, and your sinus cases. But this is what I tell my coders. You can't assume anything. It has to be clearly documented. Even though a pathologist will tell you time and time again, if I have a bone, I've done a decal. We have to see that. CMS, for one, takes a clear stand, and this is a liability issue. They say that if it's not clearly documented, you didn't do it. You have billed for a procedure that you didn't document. No documentation, no billing. The next item is almost a reverse of the first one. It's when you dictate a procedure and you don't code for it. Now, I put a little quotation about the pathologists who do their own coding. We get coding in different ways. We have a lot of pathology groups who do their own coding. We get it either electronically or we get it on paper. But they've done their coding and they've applied the codes. And when we're reviewing these cases, we see handfuls of add-on codes. Examples can be a decal, your special stains, group 1, group 2, MDOs, frozen sections when there's additional tissue blocks, and cell blocks that are performed on fluids. I don't know how many times that I've been sitting with groups and we've been talking about cases, and I'm looking at their coding and how we build it, and I'll say, gosh, I know it was a big case. I see that you performed a special stain on each specimen, but you didn't include the CPT for billing. And they'll say, that case was one of my top referring physicians. I never want to feel like I'm overbilling their patients. It was a big case. Did you see it, Liz? There were 8 specimens, multiple stains. That's going to be a huge bill, and he's going to be calling me. Well, You always, when you're getting audited, you want to think, I want to make sure that I'm capturing and I'm billing for what I've done. You don't want to ever not dictate something and bill it, but you also want to bill what you've done and dictated it. I always tell the coders and I tell the pathologists, if you did it and you documented it, you need to bill it. You need to bill for the services you have performed. You need to be compliant. Very important. The next issue is quantities of service. Now let me, just for some background, I have a lot of coders on here, so let me go through this statement. I know that you pathologists, that you know this. But the unit of service is the specimen. It's important to know and to understand it in order to properly bill it. A specimen is tissue or tissues that are submitted, and they require review individually to present a diagnosis for the referring physician on the case. Sometimes we get one container, and it contains multiple specimens. Sometimes for a surgery, you get a bunch of containers. So let's give some examples. First, I want to say one thing. These examples are not when you have a dermatologist or a physician who routinely sends you skin tags in a container, multiple tags. The requisition says skin tags. There's just maybe 5 pieces of tissue, one container. This is one specimen. What I'm talking about, and a good example, is bilateral tonsils. Routinely, we see the tonsils in one container. But the surgeon has done something with these tonsils. He's placed a tag, a suture. He's identified the left tonsil that he removed from the right. Very important. The requisition that has come to you with that container clearly states that a tag was placed on the left tonsil. So it's brought in, it's accessioned into the pathology lab, one container, we're going to have a left tonsil tagged or sutured. The requisition clearly states it. It's brought in, it's grossed, you've done everything you need to do, it's run through histology, you have your slides, you have a representative from the left and the right, and you clearly dictate in your report that you have these bilateral tonsils with a tag on the left, and you, in your diagnosis, you state that. Left tonsil, diagnosis, right tonsil. You're clearly able to state left and right. Wonderful. You can now bill 88,304 times 2. I am talking about just simple bilateral tonsils. Again, just the coder in me has to state this. This is a tonsil biopsy. It is not a 304. It is an 88,305. It's important to note if the tonsil is done and removed for a cancer, it's a 309. But this is just your routine tonsil. The same rules do apply for our sterilizations. A lot of times in the same container, we'll get the fallopian tubes, and we have the surgeon who's clearly identified the left with a suture from the right. Another example, and it's one that I see a lot, and actually saw yesterday and had a good conversation on, is placenta. I'm going to use an example of a third trimester placenta. Third trimester, 88,307. Again, second trimester, 88,305. It is very important for coders to know the trimester. Sometimes that does not come over in the clinical history, just a note. But this twin third placenta is submitted, everything in the container. You've got the placenta, you've got the cords. However, there's no clamp, there's no suture, nothing is inked. You can't tell baby A from baby B, basically. It's one specimen, 88,307. However, if that physician has submitted it to you on one container and they've used a clamp or a suture or some type of device to let you know that cord A came from baby A or the second cord is baby B, just something to let you know one cord from another, you can separately identify each, and you can render a diagnosis saying that the clamp on cord of baby A, and then talk about the second baby B. Clearly, it's now 2 specimens, 88,307 times 2. It's all in how you receive it and how you document it. Still continuing on quantities of service, let's kind of change the scenario up. A lot of times in the lab, we get tons of containers from a surgery. Let's use the scenario of just a uterus. They had a hysterectomy. The clinical history, there's no malignancy. It can be anything from fibroids, pelvic pain, bleeding, but they've undergone a hysterectomy. The surgeon has removed the uterus, the fallopian tubes, and the ovaries, and they've submitted everything with the clinical history in multiple containers. The specimens are identified, they're processed, there's no additional findings, nothing unexpected. The clinical history, definitely, the pathologist is in agreement, processes the specimen, but even though it was 3 containers, it's just 1 specimen. That would be an 88307 in this case. You really need to watch that. There are times when you're going to have in a container or in separate containers, the ovary could possibly have a teratoma. To make sure you document clear findings, you could report additional codes. Another case that I'm not mentioning here that comes to mind are breast cases, radical mastectomies. The patient has a clinical history of breast cancer, and they undergo a radical mastectomy. In there were 2 containers. One container contains the breast in the left breast. The second container contains a dissection of the axillary lymph nodes. Now, this is a radical mastectomy. It's clearly stated. You can combine both of these specimens, and you would bill out an 88309. So it would be an 88309 for the radical, despite the 2 containers. I am not talking about lymph nodes. That is separate 307s. I'm just talking about the axillary dissection along with the breast tissue submitted in 2 containers. The next item is bundling into other CPT codes. Now, I know that a lot of you are familiar with the NCCI Edits, which is the National Correct Coding Initiative, which is an automated edit system that controls the CPT code pairs. And it can be reported. It's kind of telling you what you can report together on the same day on the same patient. It was developed by CMS and is now used by Medicaid. The goal is to take mutually exclusive code pairings and consider the components of these codes and make sure you're coding to the highest level. They're kind of taking a look at your codes, making sure that if you have one specimen, whether it's like body fluid's a very good one, the site of pathology services. If you have fluid and you're doing several preparations on the same specimen, that you're not coding for both. They don't think that's medically necessary. Now, I know that AMA and other organizations disagree with this, but again, we're talking governmental, your Medicare and your Medicaid services. They say clearly that you cannot bill an 88112 and a 104 on the same specimen. Now, we discuss this a lot in our auditing and when we're auditing cases. And the pathologists say, well, I'm just going to put a 59 modifier on it for a distinct separate procedure. Well, you can do that, and granted, if it's the same specimen, that's not a wise choice. However, if you have separate specimens where you perform separate cytologies, we would use the 59 modifier. A 59 modifier, you really want to watch how you use it. There are definitely instances where we do use it. We use it for bilateral bone marrows. Certain carriers ask that we use it when we have multiple units of the same code. But we can provide the documentation needed if it's requested, and that's very important. There are also edits under the CCI that apply to your fine needles and your frozen sections with touch prep. I encourage you to look on the CMS website and look at these edits. If you can't find it or you don't know where to go, definitely you're going to have my information. You can get with me after the presentation, and I will point you in the right direction. The 5th item is reporting and submitting pending stains. Now, this is one that is very important and one that we see on a daily basis. So what happens is you have a case and you need additional testing, whether it's, immunostains, immunohistochemistry, you need additional tests in order to help with the diagnosis or even stage a cancer case or a lymphoma. So either you're able to do them in your lab or you can send them out to another lab. But we're still pending some information. The original report has already come over for billing. Clearly, we do see it's pending things, but it has been billed. You have to make sure that we get that addendum. We need to see it. It needs to be sent to our office. Whether you send it electronically or on paper, we have to verify that you did perform those tests. We also, if you send out the lab, but you do the professional component, we need to see it. Not only do we need to make sure that you're providing the right code, we need to have background information. Was this manual, computer-assisted technology? There's lots of things that we need to see within that report. So I just encourage you, when you have these situations, to make sure that your billing service is aware of getting the final, where they can see the results and how it was performed. With all that said, it brings us to auditing. All the items that are mentioned are items that I commonly go over with groups when I audit. I love auditing. I think it's a great thing, but I know every time I mention it, I have different groups frown at me. That it's just a bad word. They think, oh my gosh, CMS. But auditing is great. It's educational. It's a wonderful time to bring your group together and bring the pathologist and discuss what you're doing and how you're doing it. So many times when I'm in the office, I'll say, where did you come up with that CPT code? And they will dust off a CPT book from 2004. We're in 2013. It is important for you to have current material in your office for whoever is assigning these codes to reference. I know it's rare in anatomic pathology that we get new codes, but clinicals are changing, and you need to know your codes and have current information. I think that auditing is a wonderful time to get together. A lot of groups don't get together and discuss cases out for coding. They might discuss findings and diagnosis, make sure they're all in agreement. We never want anything to happen, no malpractice, but they don't discuss what codes they're assigning. It's critical. I found it is so nice to be a pathologist with the billing, with the coders, and have a discussion, to do a roundtable, and to just talk about the findings and what you're seeing. You can teach us so much as coders, and we can guide you in what we need to see in the report in order to bill for it. It's beneficial. View it as educational, great compliance. It ensures that you're not only providing quality services for your patients and the rendering physicians, you're also ensuring the accuracy for the billing of these services. I'd also like to say that we all make errors. We're human. It is going to happen. But we need to take steps that are positive to avoid it, to work together, to learn from it. We want to communicate with each other, with your partners, your billing companies, your staff, so we all are on the same page, have the most current information, and aware of documentation, issues that arise, edits that are in place, so that we can all ensure compliance, good coding, and good service. We never want to miss reimbursement. Sometimes auditing will find issues that lead to refunds. But other times we find issues that lead to loss of revenue because you haven't documented. There's so many wonderful things that can come out of this. Now, with that said, turn the presentation over to Dr. Howard Robin, who's going to talk about a very hot topic in pathology right now, and that's molecular pathology. Dr. Robin?
Thank you, Liz, for a very informative discussion, and thank you, Trish, for the kind introduction. Today I'd like to discuss the current state of reimbursement for molecular diagnostic testing in the United States. I'll begin with learning objectives, provide some necessary definitions, review the past reimbursement methodology, which always allows you to understand the present reimbursement schema, and then provide your lab with a plan for molecular diagnostic testing in the future. Our learning objectives include discussing the 2013 coding changes for the molecular diagnostic laboratory. We'll define the role of molecular diagnostic testing for your patient base and evaluate the risks and benefits of offering molecular diagnostic testing in your laboratory. And ultimately, hopefully, you'll be able to make a determination of what's best for your lab in terms of molecular diagnostic testing today. Today, should you build the test and offer it in your lab, or should you send it out? Let's get started. Let's review some definitions. Molecular diagnostic testing is here today because of the Human Genome Project that took place in the 90s and early 2000s. It led to this whole concept of personalized medicine, and you read it in magazines and newspapers and hear it on TV all the time, and that is individualizing treatment for your patient based either on the patient's genome or the characteristics of the patient's cancer. We'll talk about stack codes, the way in which we did it in the past, which was a procedure-based way to bill for our molecular test, the new concept of the MAAs, the Medicare administrative contractors appointed by the Medicare or CMS. Previously, we knew them as the Medicare fiscal intermediaries. We'll talk about crosswalking. That's where you match a new code to an existing code or codes to determine the appropriate payment rate. This is the method that CMS thought was most feasible to switch from the old stack codes to the new molecular codes. However, CMS felt that they did not receive enough information to compare the new codes to the existing, and so they told their MAAs to gap fill. And CMS has ruled that gap filling now be used to price these new molecular codes. The molecular contractors were supposed to develop these codes by April 30th based on local pricing patterns. What did labs in their community charge for these tests previously? What were the discounts on the charges? What are the required resources? What did other payers pay for these services? And what were the charges, resources, and payment amounts for the tests that would be comparable? And after 1 year, by the end of 2013, CMS was planning on taking all of these charges and getting a median price and using that median going forward in 2014. We'll talk about Tiers 1 and 2, the most common molecular diagnostic test in Tier 1, and then the least common in Tier 2, and then those laboratory-developed tests that are offered by molecular diagnostic laboratories known as Multi-Analyte assays with algorithmic analysis. So let's move on and talk about the beginning of molecular diagnostic testing, or the recent resurgence of molecular diagnostic testing, all related to the Human Genome Project, where we identified genes that were associated with specific diseases, which allowed the research scientists to map various molecular pathways. And then, of course, the research is then developed into molecular assays, and these molecular assays are clinical laboratories, and then used in sophisticated data mining, we're able to produce results that will help our physicians provide optimal care for the patients. Personalized medicine, I like this definition. It's the breakthrough targeted therapies leading to customized treatment, maximizing effectiveness, and minimizing their side effects. The important message here is that for hundreds of years we've been treating patients with the same medication for a particular disease and we haven't taken into account the individual's genome or the individuality of the individual's cancer. And so one size does not fit all. The goals of personalized medicine are to identify this link between the gene and the disease. Once you've identified a gene associated with the disease, you can develop the diagnostics to look either for the mutant gene meaning the chromosomal abnormality that leads to the disease, or the wild type gene which normal individuals carry. This leads to commercially available molecular diagnostic tests, and many of the pharmaceutical companies are looking for molecular diagnostics that support the use of their molecular therapeutics. So let's take a look at some of these predictive therapeutics. Probably the 5 most common genetic assays performed on cancers today are KRAS, BRAF, EGFR, BCR-ABL, previously identified in 1960 as the Philadelphia chromosome, and EC. And these genes are associated with colon cancer, malignant melanoma, lung cancer, chronic myelogenous leukemia, and lymphomas. And generally the targets are enzymes. KRAS codes for an enzyme, GTPase. BRAF codes for serine-threonine kinase. And EGFR and BCR-ABL and ALK all code for tyrosine kinases, which are usually cell surface receptors. By running these tests, we can predict the patient's response to colon, lung, melanoma, brain, chronic myelogenous leukemia, and lymphomas. These are common cancers in the United States today, and for the first time, we have therapeutics that are effective in late-stage disease. The great hope of predictive medicine. The IVD space, this is molecular diagnostics, is the fastest growing area. In 2011, the market size was close to $5 billion. If you look at the graphic on the right-hand side of your screen, you can see that in 2004, molecular diagnostics were in their infancy and they were growing at 15% per annum. Over the next 5 years, molecular diagnostics are poised to grow 9.1%. In 2015, it'll be 3 to 4 times, the growth will be 3 to 4 times that of your core business. So if your molecular diagnostic business grows by 9%, your routine hematology and chemistry by 1 to 2%. By 2015, it's predicted that 30% of all clinical laboratory revenues will be generated in the molecular diagnostic space. In order to understand the present and also the future, it's important to look back at the past. And in the past, and the past is just recent, December 31, 2012, when we were billing for molecular diagnostic tests, it was procedure-based. We looked at extraction. We looked at PCR. And the number of extraction steps and PCR steps, et cetera, determined how to bill for. This was a complex system. It led to inconsistent coding between laboratories. The payers, Medicare, et cetera, they would receive codes to know what analyte was being tested for. And so this led to abuse because some developed inventive procedures, and Medicare said, that's it. We need to have a new system, and so they said to the AMA back in 2010, go invent a new system that's analyte specific. We want something that's value-based, not cost-based. So AMA back in 2010 developed the current system, and they put it into 2 tiers. Tier 1, which is the most common gen tests that are currently being performed, in the United States today, about 116 different analytes that are associated with specific disease codes. This hopefully would lead to consistent billing practices and consistent reimbursement. It's independent of the procedure performed in order to generate a result, therefore less prone to abuse, and potentially would drive laboratories to utilize the best assays in order to get the result for the referring physician. And because it's going to improve patient outcomes and reduce expense, it's therefore considered a value-based reimbursement. Let's take a look at 4 of those genes that I showed you before. KRAS, associated with colon cancer. Palmetto, GPS, the Medicare administrative contractor in California, is willing to pay $226. The cost of therapy for patients who have the wild-type KRAS is about $25,000 a year. BRAF, which is a mutation that identifies individuals who have metastatic malignant melanoma who would benefit from a very expensive therapy, $56,400 a year. They would reimburse $56. The cost of materials for BRAF are 3 to 4 times the $56 that have been suggested as a reimbursement by Palmetto. EGFR is a gene that's associated with lung cancer. Now, for the first time, we have effective therapies for individuals with widespread lung cancer. The reimbursement is $36,000 for the cost of the therapeutic, but only $116 payment for the diagnostic test. BCR-ABL, which allows us to monitor patients with chronic myelogenous leukemia, where there is a very effective therapy, Gleevec. The cost of treatment is $100,000. The payment for the assay, $108. What's going to happen here is that there will be a much greater investment going forward in developing therapeutics than diagnostics. But it's the diagnostics that tell us which patients will benefit from that therapy. Just an example, if you have KRAS and you have a mutation, you won't respond to the $25,000 therapy. In fact, these patients who have the KRAS mutation will actually have a shorter survival. So it's really important before you use these new therapies that you perform the genetic test. Tier 2 are the less common genetic tests, and you can look on the right. It's uncommon for the doctor to order a full gene sequence for Mediterranean fever. Probably very few people out there know what Joubert's disease is or syndrome is, and the need for full gene sequencing. This is procedure dependent. There are 9 procedural categories. They're based on complexity, but it does lead to consistent billing practices for 10% of the genetic tests, which hopefully would lead to consistent reimbursement, less prone to abuse, and value-based. Multi-Analyte assays, these are laboratory developed. Typically, they're offered by a single clinical laboratory or manufacturer, such as Oncotype DX and Mammoprint for breast prediction and prognosis, the ASH FiberSure for monitoring and treating patients with chronic hepatitis C virus infection. These are molecular assays that are analyzed using a sophisticated algorithm, and the output is either a numeric score or a probability percentage. Important thing here is that when you use an MAAA and you get a specific code, it does not mean that any health insurance coverage or reimbursement policy will follow. So you may have a code, but you may not get paid. Medicare assign the responsibility to the Medicare administrative contractors, of which there are 15 throughout the United States. The only one that's been active is Palmetto GBA in California, Nevada, and Hawaii, and they used gap filling instead of crosswalking and came up with a fee schedule that has been adopted by a few of the other MAACs. This fee schedule is felt to be somewhere between 25 to 30% of the previous stack code reimbursement. Others say that it represents actually 34% of the total reimbursement. I may have misstated that. 25 to 30% reduction was one analysis, and then others say that it's only 34% of the previous stack codes. Any way you look at it, it's reduced reimbursement for performing very sophisticated and expensive molecular diagnostics. The gap-filling process was supposed to begin in 2013. CMS, after telling the AMA to come up with this new system, 2010, got started putting it on the clinical lab fee schedule in November of 2016, and supposedly it will be fully implemented in 2014. The current problem is that many labs have not been paid, no prices have been set, and those individuals who have submitted claims using the Tier 1 and Tier 2 codes may not get paid at all. What can we do? We need to keep up the pressure on the MAACs. We need to share the cost of goods and testing. The clinical laboratory scientists that perform these tests get paid very well. It may even be essential to contact our legislators, congressmen, and senators in order to tell them that a lot of labs may close if reimbursement does not improve, and then, of course, submitting comments and concerns directly to CMS. So what do we do now? If you're not currently in the molecular diagnostic business and you recognize that this is the growth arena, do you build or do you buy? The molecular diagnostic market, graphic here, predominantly PCR, but other methodologies. Do you invest for equipment and reagents? Well, you might want to wait until you see what the reimbursement looks like. You need to make a list, the pros and cons. Do you build the laboratory tests? There are development costs. You have to acquire the instrumentation, which can be expensive. You need to develop the standard operating procedures and quality management plan. You need to figure out who you're going to market your assays to. You have to have a proficiency test, and for many of these molecular diagnostics, you might not be able to find a proficiency testing material, so you need to be creative. You need the information technology. Labor is very expensive in the molecular field. Cost of goods are very high. The cost of goods for the KRAS testing are 3 times that of the reimbursement set by Palmetto. And of course, you have the cost of billing and current inadequate reimbursement. If you decide to send out these molecular tests today, you would choose a lab that has sufficient volume to give you the turnaround time that you require. You want to use the best possible laboratory. You might be able to get good pricing on the send out because you would use the AMA Tier 1 and 2 and set values. This would allow you to project what your annual expense is, predicated on the number of assays that are ordered by your referring physicians. You can focus on what you do best for now. You certainly want to the volume of send-outs for molecular diagnostic testing. You want to monitor to see what the reimbursement changes are, and at the right time, you bring the test in-house, and that might be the best way in which to deal with molecular diagnostic testing today. It's important to learn from the past, live in the present, and believe that in the future there will be better reimbursement for molecular diagnostics. I'd like to turn the program back over to Liz, and thank you very much.
Thank you so much, Howard. I would like to thank everyone for attending today. There are so many different types of questions that you might have had that we didn't cover, and so many different ways that each group documents their cases, I know for me, for auditing purposes. Trish will be sending out this webinar presentation along with our contact information. If you would like me to review some of your cases, I encourage you to take us up on this auditing offer and send them to me. I would definitely like to go over them and discuss any kind of question you would have, either on something I covered or something that I didn't cover. Again, thank you so much for attending. Trish?
Thank you, Dr. Robin and Liz, for a great presentation. I certainly appreciate your time and appreciate the time of everybody that has joined us on the line. We just had one question come through during the presentation for you, Dr. Robin. And could you just, the question basically states, could you please repeat what you had mentioned regarding the growth of molecular diagnostics through 2015?
Could you repeat that question again? I'm sorry.
That's okay. Please repeat what you said regarding the growth of molecular diagnostics through 2015.
9.1% per annum, per year.
Thank you very much. And that was the only question that we had come in through our chat session. So as a reminder, and reiterating what Liz just said, I will be sending out a copy of today's slides along with an audio playback option that you can listen to at your convenience. And if you do think of any questions between now and then, please feel free to email those to us, and we will definitely get those answered for you as soon as possible. And with that, we'd like to say goodbye and thank you again for attending, and we'll see you at a future webinar.